Welcome to This Explainer. If you're a medical intern, a general practitioner, or honestly just someone fascinated by clinical diagnostics, you are in exactly the right place. Today, we're focusing on one of the absolute most common presentations you'll see in any outpatient clinic, vaginal discharge. Our goal over the next few minutes is to build a rapid, highly reliable clinical decision framework directly from our source materials. We want you to be able to confidently diagnose and manage the big three pathogens. We're going to visually construct a really simple decision framework to make a complex issue beautifully simple. So picture this. A patient walks into your clinic complaining of vaginal discharge. What's the very first question that should come out of your mouth? Seriously, take a second and think about it, because our sources highlight that your entire clinical pathway, the path that dictates exactly what medication you're going to write down on that prescription pad, hinges on this one single critical triage question. Here's the structured roadmap we'll be following today. First, we'll establish that primary triage question. Then we'll explore the fungal path with candidiasis. After that, we'll differentiate bacterial vaginosis and trichomoniasis. We'll follow up with the targeted treatment protocols, and finally wrap up with the golden rule of partner management. Step by step, we're building out this differential. Section 1. The vaginal discharge triage. Starting the clinical pathway. Okay, let's dive into this. The answer to our initial question actually splits our diagnostic tree into two totally distinct branches based entirely on odor and pH levels. According to the source material, if the discharge is odorless and the vaginal pH is normal, meaning under 4.5, boom, your mind should immediately go left down the fungal path. You're thinking candida. If, on the other hand, the patient reports a foul odor and the pH is elevated above 4.5, you swing right. You are now looking at either a bacterial issue, like bacterial vaginosis, or a parasitic one, like trichomoniasis. It's a really simple binary split, but it is the absolute foundation of your diagnosis. Section 2. Candidiasis, the silent itch. Identifying the fungal path. Let's start by walking down that left side of the tree. And this brilliantly illustrates the classic presentation of a candida infection. If it's fungal, the source notes the patient will typically describe a white, cheese-like discharge. I want you to anchor that sensory memory in your mind right now. Cheese-like and odorless. But the real hallmark symptom here, the thing that's actually driving the patient into your clinic, is intense, severe itching. Remember, a white, clumped discharge with severe itch, zero foul odor, and a normal pH under 4.5 points squarely at candidiasis. So how do we actually treat it? Well, the sources lay out a highly specific 2-week protocol. Step 1 is systemic. That's a 150 milligram pill of fluconazole, often known by the brand name Flucarol. They take one today and a second pill exactly 1 week later. Step 2 is local. That's Gynosol cream or a vaginal suppository used daily for 3 days. And step 3 involves hygiene, specifically using a vaginal douche morning and night. Now here's a crucial clinical pearl from the sources. Always check if the patient is pregnant before prescribing. If she is, systemic antifungals like fluconazole are strictly contraindicated due to teratogenic risks. In that scenario, you would rely entirely on local treatments. Section 3. Differentiating BV and trichomoniasis. Teasing apart the foul odor path. Let's shift focus back to the right side of our diagnostic tree, foul odor. Now, this requires us to distinguish between two trickier culprits. Both present with a bad odor and an elevated pH above 4.5, but look at the nuances in this matrix. Bacterial vaginosis, or BV, often yields a positive whiff test, meaning a strong fishy odor, and is typically clear, grayish, or yellowish. Trichomoniasis, however, takes on a greenish tint. Texture is another huge clue. While both are copious, trichomoniasis often presents with a really distinct froth or foam. Finally, the itch. BV generally doesn't cause severe itching, but just like Candida, trichomoniasis will cause intense itching right along with that foul, fishy odor.
Section 4. Targeted treatment protocols. Specific pharmacological instructions. Now that we have our diagnosis, it is time to write the correct prescription.
If your diagnosis is bacterial vaginosis, you're looking at a week-long regimen combining both oral and local metronidazole. The sources specifically outline prescribing a flagyl pill every 12 hours for a full week. Right alongside that, you provide an omeprazole suppository, which is just a local metronidazole, to be used morning and night also for 1 week. It's a great, sustained, dual-action approach to clear out that bacterial overgrowth. Now, what's really interesting about this slide is this single number, 4. I want you to literally burn this number into your memory. Because when you're dealing with the other foul-smelling pathogen, trichomoniasis, this represents the exact pill count for the entire protocol. Unlike the week-long sustained treatment we just saw for BV, trichomoniasis requires a massive single-dose strike. The sources state the protocol is 4 pills of 500 milligram metronidazole, totaling 2 full grams, taken all at once. You can use Flagyl or another brand mentioned in the sources, Vagigan. Vagigan is actually super helpful because it conveniently packages the exact 4 pills you need for this single-dose strike. One massive dose, taken at one time. Section 5. The Partner Management Rule. Who else needs medication? This is a critical clinical question every GP has to answer before the patient leaves the clinic. What about the partner? The crucial point is making this golden rule stick. Because trichomoniasis is a sexually transmitted infection, the sources are crystal clear. It absolutely requires the partner to be treated. And they must take the exact same 4-pill, 2-gram single dose. If you skip this, the infection is just going to bounce right back. Candida, on the flip side, is an overgrowth of normal flora, not typically an STI in this context, so we do not require the partner to be treated. So the next time a patient sits down in your clinic complaining of a foul-smelling, greenish, frothy discharge, will you be ready? Will you remember exactly how many pills to prescribe her and her partner? By using this simple diagnostic framework, combining odor, pH, and texture, you now have a highly reliable system to triage and treat the big 3 pathogens. You're completely empowered and ready for your next shift. Thanks for joining me on this explainer. Keep learning out there, and I'll catch you next time.